Hey, hi everybody. My name is Dr. Tree Doe. I'm medical director at CHCN. Thanks so much for your time, your lunch time, to hear a wonderful talk by Dr. Eric Collins. I'm going to do an intro for Dr. Collins. He grew up in South Central LA and got a neuroscience degree from UC Santa Cruz, so he's a banana slug. And let's see, he went to medical school at University of Kansas Medical Center, did a neurology residency and neuromuscular disease fellowship at USC. Is that the Trojans? Am I getting that right?
Yes, it is the Trojans. I'm not sure if they use the the product because there's a high birth rate down there, but
And Dr. Collins has been practicing neurology in the East Bay since '93. He's a former president of the San Francisco Neurological Society and has a faculty appointment with Touro University, or Touro College. So yeah, without further ado, Dr. Collins, take it away.
Okay, so we have to do disclosures here. I have no financial relationships except to my employer. And let's see, you should only claim the maximum that you actually attended of this. I will discuss off-label use of medication since most neurology medications are used off-label anyway. And I'm opinionated and not easily redirected, so there's that. So I want to talk about the objectives of the talk today. At the conclusion, I want people to be able to perform an appropriate examination of the peripheral nervous system. And you can't do a complete neurologic examination on any patient. Nobody can. It would take about 2 days to do every known neurologic examination technique. But there's certain things that you do need to check if you suspect peripheral neuropathy. And it's very important to understand the time course and the patterns of deficits. This is really key to being able to make a diagnosis, is understanding the patterns and understanding the time course. I can't overstate that enough. And order, if appropriate, order correct electrodiagnostic testing for each patient. And differentiate between potentially treatable causes of neuropathy and conditions limited to symptom management. If it's clear that there's not going to be a treatment for the neuropathy, there's not a whole lot of point in doing a big neurologic evaluation and a big workup. One thing I want to say that I've noticed during the lockdown is I'm getting a large number of patients that are referred for peripheral neuropathy, needs EMG, and that decision was made over a video call. You can't evaluate peripheral neuropathy over video. You just can't do it. And many of these patients, at least 1 to 3 a week, don't have a neurologic problem. They have an orthopedic problem. So it's very important to do an examination on these patients. So what is neuromuscular disease? I think that term is misunderstood. Neuromuscular disease is just diseases of the peripheral nervous system. Just the peripheral nerves and muscles, not the central nervous system. I've heard people refer to multiple sclerosis as a neuromuscular disease because, well, there's nerves involved and there's muscle weakness. No, not the same thing. Peripheral nerves and muscles are neuromuscular disease. And this is an old picture from Vesalius of the entire peripheral nervous system. All these peripheral nerves, it's a very big organ. And it requires particular examination techniques in order to understand what's going on with this. So this cartoon here just shows the central nervous system, represented by the spinal cord here, and the peripheral nervous system. And there are sensory nerves, and there are motor nerves. I'm hoping people can see my pointer. I'm not sure. And the sensory nerve, the cell body for the nerve is outside the central nervous system. And the axon of the sensory nerve runs both up the spinal cord and down through the peripheral nerve. It's a single axon, so thin that you can't see it with the naked eye, but yet a single axon that can travel all the way from the spinal cord down to the tips of the toes, a single cell. The motor neuron, the cell body, is actually within the spinal cord. And there are certain diseases that affect the cell body within the spinal cord. But the rest of the nerve cell is the axon in the peripheral nerve. So these two components and the location of the cell bodies becomes important later, as we'll see. But these two, sensory and motor, plus some autonomic fibers, comprise the peripheral nervous system. Now I'm going to be using the word motor unit. So we need to understand what a motor unit is. Now, of course, muscles don't work unless there's nerves attached to them. And nerves, if they're motor nerves, aren't doing anything if there's no muscles attached to them. So a motor unit consists of the cell body of the motor neuron, the axon, all the Schwann cells that are myelinating that nerve, the muscles that are attached to that nerve, and the motor end plate, where the acetylcholine is released. So all of this together, all of these cells together function as a single unit. The neuron sends an impulse down the nerve, acetylcholine is released, the muscle contracts. So this all functions as a unit, and we call this the motor unit. However, each nerve is not attached to only one muscle cell. Each nerve is attached to hundreds or thousands of muscle cells, and all of these muscle cells contract at the same time when an impulse comes down from the nerve. These different motor units are not in one clump, they're interspersed with each other in a checkerboard pattern. And if we look at a cross section here, this cartoon shows 3 motor units. We have motor neuron here, the orange one, and it's connected to all these orange muscle cells. The red ones connect to all the red muscle cells, the green ones connected to all the green muscle cells. The way that we increase strength in a muscle, the muscle's completely relaxed, we contract a little bit, we contract a little bit more, has to do with recruiting more motor units. Because remember, all the muscle cells attached to a nerve cell contract at the same time. You can't contract some of the muscles within a motor unit. So in this cartoon here, we have 4 different states of contraction. We have completely relaxed, we have 1 motor unit, we have 2 motor units, we have 3 motor units. So we can vary the strength of the muscle. Now, what happens if one of these nerve cells is damaged or dies? Remember, the muscle cells, even though they're attached to the nerve cell, are separate cells. So the muscle cells don't die if the nerve attached to them is damaged. They rapidly shrink and they lose all their internal contractile apparatus, but they're still alive. And they're actually secreting cytokines to cause these remaining nerve cells to grow new branches and reattach. So if a nerve injury causes rapid muscle atrophy, but as the nerve recovers, and peripheral nerves can recover, the muscle cell can regrow as the remaining nerve cells
Take a little walk.
attach.
Way back closer.
Is that a question? I'm hearing some voices there. Okay, so, but now you've only got 3 modes of contraction, 0, 1 motor unit, 2 motor units, so you don't have as fine of control. So people who have chronic neuropathy, they have clumsiness because they have fewer nerve cells running the same number of motor cells. So you don't have the fine control over the muscles that you would if you had more nerve cells. Another thing we need to discuss is what we call small fibers and large fibers. So a peripheral nerve is a bundle of axons, of nerve fibers, thousands of them, perhaps tens of thousands in large nerves like the sciatic nerve. And the general category is we talk about large fibers like this one here. The black is the myelin around the nerve fiber. So this is a large nerve fiber with lots of myelin around it. Down here, you have small nerve fibers with no myelin around them. There's some intermediate nerve fibers, but in general, we talk about large fibers and small fibers. What's the difference here? Well, remember myelin increases the speed of conduction in a nerve. So large fibers have a lot of myelin. They have very fast conduction. There's all the nerves that go to muscles, the motor neurons, are large fiber. You need those impulses to reach your muscle quickly. The sensory fibers that are large fibers are the fine touch, vibration, position fibers. These are the ones you can measure on nerve conduction studies. You can only measure large fibers on nerve conduction studies. The small fibers have little or no myelin and very slow conduction. There's sensory and the autonomic nerves, so temperature and pain are conducted more slowly. I think we've all had the time when we've stepped on something sharp and it takes a second before we feel that pain. Or if you've jumped into a very cold lake, it takes a second before the pain of the cold hits you. But for fine touch and your joint position, you need very fast conduction. You cannot measure small fibers on nerve conduction studies. So if a patient says that they have problem feeling temperature, they have problems feeling pain, you may have a normal nerve conduction because you can't measure the small fibers. Now, when you're taking a history of peripheral neuropathy, or any neurologic problem, but particularly in peripheral neuropathy, you need to understand that there's positive symptoms and negative symptoms. A positive symptom is something that is there that shouldn't be there, and a negative symptom is something that should be there and is not there. So motor positive symptoms, fasciculations, not a normal thing. Cramps, very common. Sensory positive symptoms are paresthesias, feeling abnormal sensations that aren't really there. Allodynia, hypersensitivity, light touch feels very painful, or just pain, which can be of various sorts, burning or stabbing or squeezing. Motor negative symptoms, weakness, obviously, but clumsiness and muscle atrophy. Sensory negative symptoms, decreased sensation, hyposthesia. Sensory ataxia, where patients have a positive Romberg and can't keep their balance because their position sense is impaired. So fasciculations are spontaneous single contractions of motor units. Fasciculations are not these things where people go, oh, my biceps twitches a couple times, and then my leg twitches a couple times, and these are big jerks of the muscles. There's really not a name for that. Fasciculations are small movements, and fasciculations are due to sick motor neurons or axons, and they're continuous generally. Cramps, tonic, painful contractions of muscles due to feedback loops and abnormal axons. So patients that have frequent cramps, unless they have an obvious metabolic abnormality, it's probably a nerve problem. And here's an example of fasciculations. I hope you can all see this. You have to sit and watch his calf. You can see little twitches there. So you're probably not going to see this on a video. important that patient come in, and if they're complaining of cramps, weakness, they got to have some clothes off. You can't do it with their all their clothes on because you can't see their muscles. Positive sensory symptoms, paresthesia. It can be tingling, burning, squeezing, stabbing, aching, freezing, shocking. There's all sorts of ways that people describe their paresthesias. And they wax and wane. Very often they're more prominent at nighttime when people aren't doing other things with their limbs or distracted by other things. And allodynia, the pain with normal touch, where you squeeze a patient's toe and they feel like you've just stabbed them with a knife. Negative motor symptoms and signs, weakness. Now this, I talked about patterns. This is very important. This should be burned into your brain. The pattern of weakness in muscle disease versus nerve disease. In myopathies, almost always, it's the proximal muscles that are weak. The patient's neck, the patient's shoulders, the patient's hips, the patient's thighs. But in a myopathy, their grip strength may be normal, their ankles may be normal. Whereas in a neuropathy, it tends to be the distal muscles, the hands, the feet, the ankles. Those are the ones that are weak, clumsy, have cramps. Clumsiness has to do with reduced number of motor units. We talked about that, where when you have less nerve fibers running the same number of muscles, you don't have as fine control. And atrophy, the most dramatic atrophy of muscles is due to nerve damage, not to muscle problems. You certainly see muscle atrophy due to disuse. Somebody has had their leg in a cast for 4 months, take it off, and the leg is obviously smaller because they're not using that muscle. That's easily reversible. But here's a patient with a chronic nerve disease, and you can see how severe the muscles are atrophied here. And here I'm going to have the patient is trying to hold his hand upright, like make a saying stop. He's got a wrist drop, fingers dropped. You can actually see the spaces in between the bones because the muscles are so atrophic. Another patient with a chronic nerve disease, you see this picture of clawing of the fingers, where the patient can't straighten the fingers completely because the small muscles in the hands are necessary for that last bit of extension. And you can see the atrophy in the interosseous muscle here. Negative sensory symptoms. Usually when a patient says they're numb, they're not numb. They're talking about paresthesia. Well, what do you mean numb? Well, it tingles. You know, well, it has a weird burning sensation. But then they actually can feel things. So don't take histories at face value. Again, you have to examine the patients physically. If they have decreased pain sensitivity, of course, they can get tissue damage and not know it. And ataxia, if they have loss of joint position sensation, they just can't walk without support because they can't tell where their legs are in space. Additional signs, some patients with chronic neuropathy get an irregular tremor. This is not a rhythmic tremor like a central tremor or Parkinson's. It's kind of tremulous, irregular movements, usually of the fingers due to delayed proprioceptive signals. Reflexes tend to be decreased in peripheral nerve disease, whereas, of course, central nervous system disease, they're increased. The worst hyporeflexia is when they have a demyelinating nerve disease. They tend to be areflexic, like in Guillain-Barré syndrome, no reflexes. If they have muscle disease, even though the muscles are weak, their reflexes may be normal because the nerves are normal. With the autonomic fibers, they can have skin changes. We've all seen the diabetics where the lower part of their legs has no hair and it's red. And that has to do with autonomic fibers going to capillaries and hair follicles.
Dr. Collins, we have a question from the audience.
Sure.
The question is, how do patients describe the sensations of fasciculations if not as twitching? Or are fasciculations more of a visual sign?
That's a good question. They say it feels like there's something crawling under their skin. They can say it feels like there's worms crawling under their skin. And of course, if you look at it, like we saw in that patient's calf, it kind of looks like there's worms crawling into the skin. So it's not you know, big repetitive twitches. It's the whole muscle seems to kind of be writhing, and they describe a feeling of worms crawling under the skin. So the time course, super, super, super important in any neurologic disease, but as it applies to neuromuscular disease, well, if a patient suddenly has loss of sensation and strength in a particular part of the body, it's generally due to trauma. They get stabbed in the arm and it hits one of the nerves. So peripheral nerve disease, the only acute way you can have loss is with trauma. Subacute, over days to weeks, these are the patients we worry about, okay? So a patient is gradually becoming weaker and weaker, or worsening sensory loss over days or weeks. Certainly toxic things, including chemotherapy. And arsenic is another one. I've actually seen that in someone who had some rat poison and tried to commit suicide by drinking arsenic, and it causes terrible nerve damage. But autoimmune diseases, often treatable. Guillain-Barré syndrome is certainly one that we think of as progressing rapidly over days to severe weakness. But other autoimmune diseases can progress over weeks. However, nerve diseases that progress over years, 5 years, 10 years, patient has had numbness in the toes, and over 10 years, it's gradually gone up to above the ankles. You're not going to find a treatable cause for these patients. You're just not. Diabetes is obviously the most common one that we can identify a cause for. Idiopathic, also very common, which means we do a big workup, find nothing. But there's a lot of undiagnosed Charcot-Marie-Tooth, which is inherited polyneuropathy, out there. And if patients have a mild case, they're going to have gradual weakness, atrophy, cramps in the hands and feet over many years. Obviously, genetic disease, not treatable at this point. If patients have fluctuating symptoms, they have some tingling in one part of the body that goes away, and then it moves to another part of the body for an hour or two and goes away. That's not neuropathy. Okay, neuropathy doesn't fluctuate like that. Can you give me a glass of water? So again, the pattern is everything. Proximal weakness, usually muscle disease, shoulders, necks, and hips. Distal weakness, hands, feet, ankles, that's generally neuropathic. If it's focal weakness, just one part of one limb, that's going to be an individual nerve or an individual nerve root. When you're testing strength, again, can't do this over video. You need to know the difference between give way weakness, where you ask a patient to maintain a joint position, you push, and there's a little bit of resistance, and then the patient just suddenly collapses. That's give way. The patients really have to give maximal effort, and a true weakness has a steady resistance against force. It's not like you push on it and then suddenly it collapses. That's volitional. If they have give way with sudden collapse, it may be because it hurts. Okay, they don't want to maintain the pain. They can maintain the pain, but they don't want to because it hurts. Maybe they've been to a number of doctors who just blew off their symptoms, and they're trying to exaggerate their deficit to get the doctor to take them seriously. Occasionally you see patients who are malingering. Usually that means a lawyer's involved. And you can have something that looks like give way weakness with upper motor neuron lesions, and that's called motor impersistence, but the patient doesn't just collapse, they kind of irregularly give strength. So it goes down, then they push back up, so they're actually trying. It's a slightly different thing. Again, pattern is everything in sensation as well. In polyneuropathy, we're talking about generalized nerve dysfunction, it's length dependent. So the feet are affected before the hands. Remember, it's a single cell going from the spinal cord down to the tips of the fingers. down to the tips of the toes. That's where we get the stocking glove pattern. The feet are affected more than the hands. By the time the sensory loss reaches up to the knees, people are usually getting sensory loss in the hands. If it's a focal lesion, a single nerve or a single root, you have sensory loss in the dermatome of that root. Can't check that over video. And then, does the patient have small fiber loss? Do they have loss of pain and temperature? Or are pain and temperature intact, but they can't feel vibration or joint sense position? Those are very different diseases, small fiber and large fiber neuropathy generally. Of course, sensation, testing that is subjective, dependent on their psychological state, influenced by focal pain. If somebody has pain in their shoulder, their whole arm, they may feel increased pain sensitivity or decreased pain sensitivity, not based on any peripheral nerve problem, but just due to the fact that the pain is overwhelming their brain. You have to check pinprick, vibration, position, temperature. You don't always have to check all of these. And you check side to side. You know, is the right side and the left side the same? You check proximal versus distal. If they can't feel pinprick in their toes, you gradually move up their leg until you find where they can feel the pinprick. And it should be reproducible. So if you check the same limb again, you should get the same findings. Graphesthesia, stereognosis, I'm not going to talk about those because those are tests of brain function. Friend of the dog. So remember that a nerve, very thin fiber, you can't see it with the naked eye. The cell body is near the spinal cord or in the spinal cord, but yet this entire nerve needs to function. So proteins need to be moved all the way down the nerve. And mitochondria need to move back and forth. And there's a process of axonal transport where things move down from near the nucleus to the distal nerve. And that can be disrupted by multiple metabolic and toxic causes. The longer the nerve, the more chance there is that something is going to go wrong with axonal transport. So the longer the nerve, the more it's affected, which is why the feet are affected more than the hands. Now, it's not just problems with the axon that can affect the nerve. You can have demyelination. So this is your nerve. You've got the axon here, and then you've got Schwann cells around it, causing the myelination, which helps with the nerve function. So in an axonal process, the axon is dying back. In a demyelinating process, you lose your myelin, but the axon may be intact. Demyelinating nerve problems tend to recover better. You just need to have more myelin as long as the axon is intact. Axonal problems tend not to recover well. So is it axonal or demyelinating? Axonal things have the typical length-dependent stocking glove, distal weakness, reflexes mildly decreased, maybe normal. They have a lot of fasciculations and cramps. And you think metabolic or toxic things usually. And axonal neuropathies, usually not treatable. Occasionally we can find some rare conditions that are. Demyelinating, not always link dependent, because you can have demyelination along any portion of the nerve. You can have both proximal and distal weakness with demyelinating, like a patient with Guillain-Barré. Reflexes tend to be absent, zero, in demyelinating neuropathies. And these are often autoimmune, and these are often treatable. So how do we evaluate these other than this clinical exam, which I've described, which has to be done in person? Nerve conduction studies. A lot of people will often order EMG, and in EMG, ordered that way can mean either an EMG or a nerve conduction study or both. So let me describe a nerve conduction study. We put electrodes over an accessible portion of the nerve. We have a stimulator. We give an electric shock here. The impulse moves down the nerve, and we measure it on our machine as a nerve discharge. In order to determine speed, you have to have distance over time. So we give a stimulation at a more proximal site, and it takes longer for the impulse to get down here. So we get another impulse, and the machine measures the time in milliseconds between these two. And so, and we get a tape measure, measure the difference here. So we have distance over time, and we know the conduction velocity. If it's decreased, it's demyelination. If the size of the impulse is decreased, which means there's less axons, we know it's an axonal problem. And here's an example of a nerve conduction study. The muscle twitches, we can measure the sensory here, we measure the muscle impulses here. The hand twitches because the nerve is activated. That's all it is, all there is to nerve conduction. So what information can you get from a nerve conduction study? Well, you can answer specific questions. Does the patient have carpal tunnel syndrome? And you're going to get yes, they do, or no, they don't. And you may get mild, moderate, severe. Any other focal neuropathies, as long as the nerve is close enough to the skin that we can measure it and stimulate it. And we can determine if a patient has a demyelinating neuropathy or an axonal neuropathy based on the speed and the size of the response. You cannot evaluate vague symptoms. The patient's arm hurts. Please do EMG. Not a useful request, and often it's going to be turned down by the neurologist who's going to go, well, let's do an exam first. You can't evaluate small fiber neuropathy. If the patient has burning pain and loss of pinprick and temperature in their feet, but yet they can feel vibration, probably going to be a normal nerve conduction study because small fibers can't be measured. And you can't evaluate a radiculopathy because, well, the lesion is inside or next to the spine, so you can't stimulate down there. So again, sensory nerve here, the lesion in a radiculopathy is here. This part of the nerve is intact, is going to be normal even if the patient is completely numb because the signals can't get across here. An EMG, we're measuring muscle responses. Actually, we're measuring motor unit responses. We put a needle, which is an electrode, inside the muscle and have the patient contract. And when they contract a little bit, we see firing from one motor unit. Contract a little more, you see another motor unit come in, contract a little more. Eventually, the whole screen is just filled with white noise, okay? If the patient is contracting as hard as they can and you only see a few motor units, well, you know there is nerve damage in that muscle. So again, EMG only measures motor units, muscle responses. So you can evaluate a motor neuropathy. What is the cause of this patient's weakness? You can evaluate radiculopathy if there's weakness associated with it, because you know which nerve roots are connected to which muscles. You can evaluate focal lesions in areas that you can't get to with nerve conduction studies, brachial plexus, shoulder girdle, lumbar plexus, and you can evaluate muscle disease because there's all kinds of weird patterns that you see in muscle responses in muscle disease. You can't evaluate purely sensory complaints. If the patient says, oh, my arm's kind of tingly and it hurts, but there's totally normal strength and muscle bulk, EMG is likely just going to be normal. You can't determine the speed of the nerves. You can't evaluate central nervous system lesions, and I've seen patients referred for EMG who's obviously had a stroke. So exam, again, very important. You can't evaluate orthopedic lesions, and again, since the lockdown, 1 to 3 times a week I have patients referred for EMG for neuropathy who have purely orthopedic lesions, and it may be arthritis, it may be plantar fasciitis, and these patients were sent over without an examination. So examination, examination, examination. And if it's a very acute nerve injury, you're not going to see the full abnormalities on EMG because it takes a while for all the abnormalities to show up after a nerve injury. We usually say 3 to 4 weeks at least. The only way to diagnose small fiber neuropathy is with skin biopsy. We do a punch biopsy at the ankle and the knee, send it off, and they stain it, and they just count the nerve fibers in the skin. And there's a normal number of nerve fibers you should have in different locations. And if it's very decreased, then we know you have a small fiber neuropathy. Patterns, again, mononeuropathy, single nerve, carpal tunnel syndrome, perineal neuropathy, Bell's palsy. Polyneuropathy, generalized nerve dysfunction, usually link dependent. Mononeuritis multiplex is an interesting thing that the rheumatologists are going to see more than most of us, and it's multiple individual nerves, maybe an ulnar neuropathy on one side, facial weakness on the other side, and maybe a median neuropathy and on one side and a foot drop on the other, but it's multiple individual nerves. That is usually some sort of vasculitis. And then, of course, radiculopathy, spinal nerve root. Again, polyneuropathy, large fiber, tingling in the feet and hands, distal weakness, small fiber, pain, burning, hair loss, skin redness. Axonal diseases cause a lot of atrophy, fasciculations, cramps, demyelinating diseases, areflexia, weakness. So what are the common things that we see for polyneuropathy? Well, possibly the largest group is idiopathic, where we never do find a cause. What we do know is that peripheral neuropathy increases with age. Studies have shown that over age 55, 8% of people have identifiable polyneuropathy. Over 65, 24%, and it just goes up with age. This is very slow progression of distal sensory loss in this type of polyneuropathy. Well, I noticed some numbness in my feet maybe 5, 6, 7 years ago, and it's slowly gotten worse. I don't have any weakness, occasional cramps. Sometimes they have pain. And if you look carefully, you may see fasciculations in the calves. You may see hammer toes. A lot of these may be undiagnosed Charcot-Marie-Tooth type 2. There's a lot of that out there, and there's at least 100 different mutations that can cause Charcot-Marie-Tooth type 2, but it's usually not a disabling condition. Length dependent, again. Diabetes, we still don't know exactly how diabetes causes peripheral nerve dysfunction. And we don't know why it is that some people with poor glucose control have no neuropathy, and other people who are in the pre-diabetes phase may have significant neuropathy. But most common for diabetic polyneuropathy is it's small fiber, where pinprick is lost more than vibration. It's length dependent in the feet and toes, and sometimes painful, sometimes not, may become painful as the disease progresses. And you may have some fasciculations in the calves. It tends to be indolent, very slow moving. There's no specific medication we can give to improve nerve function. Managing the hyperglycemia. If hyperlipidemia is out of control, that seems to make it worse as well. And how do you manage neuropathic pain? There's no magic pill that neurologists know the secret to. It's the usual suspects that we use. Gabapentin, pregabalin, which is Lyrica, they both work the same way. This is only for pain and does not improve nerve function. And I've had some patients under the mistaken impression that their nerves will work better if they take gabapentin. Not the case. It's only for pain. If they have no pain, there's no point in this. SNRIs tend to work very well. Venlafaxine, duloxetine, Effexor, and Cymbalta. And you can use these in combination. Tricyclics work very well, but they have higher side effects. Narcotics are generally not helpful for neuropathic pain. And there's a lot of companies out there selling all kinds of weird topicals with, you know, bizarre things in them. Whether those work or not, unclear. Acupuncture at least does no harm, and some people with burning pain in the feet can have significant relief from acupuncture. Vitamin B12 deficiency, one of the things you always check for. But again, it's unclear how often B12 deficiency just causes peripheral neuropathy without spinal cord problems. And you need to check methylmalonic acid, possibly homocysteine, not just B12. Less common polyneuropathies, chronic inflammatory demyelinating polyneuropathy, which is gradually progressive weakness, usually over weeks, maybe a couple of months, both proximal and distal. Some with sensory loss, sometimes not, that tend to be areflexic. This is an autoimmune condition. Again, over weeks to a couple of months. Demyelination on nerve conduction studies, elevated CSF protein. So you can think of this as a chronic form of Guillain-Barré syndrome. Charcot-Marie tooth is actually pretty common. Charcot-Marie tooth type 1 is demyelinating. They're the ones that have the high arched feet and large nerves. They can have a neuropathic tremor. Charcot-Marie tooth type 2, 100 different mutations can cause this. Probably undiagnosed. I have it myself. I have a little bit of hand weakness. My wife has to open all the jars. I get cramps in my hands and feet frequently. Here's a patient with a neuropathic tremor due to Charcot-Marie tooth. See, it's kind of an irregular tremulousness of the fingers. And then here's his feet. High arches, hammer toes. And when he tries to move the toes, they don't move normally because of the weakness of the distal leg and intrinsic foot muscles. Another younger patient with Charcot-Marie tooth has not yet developed hammer toes, eventually will, but you can see the high arches. Rare neuropathies, diabetic amyotrophy. You see this in diabetics. This is very dramatic. They have a very acute, severe pain in the thigh and one leg, usually in the femoral nerve muscles, and their quadriceps rapidly atrophies. They can't walk without the leg collapsing. And they tend to lose weight very fast and dramatically with this. They can have more than 50-pound weight loss over a couple of months. It's really dramatic and it's super painful. Sometimes IVIG can improve this, sometimes not, but it recovers gradually with time. It may take a couple of years. Acute painful diabetic polyneuropathy.
Sorry, Dr. Eric, we have a couple of questions.
Sure.
If you wouldn't mind pausing. There's, so the first set of questions is about checking folate when checking B12. Is it necessary?
Yeah, well, that's why you check methylmalonic acid, but folic acid itself doesn't have a huge role in peripheral neuropathies. You know, the main thing is, of course, you know, you don't see the hematologic changes if they have folate. So folic acid itself doesn't have a huge role in peripheral neuropathy. It's the B12 and the methylmalonic pathway that affects the peripheral nerves.
Yeah. And the other question is alcohol abuse and neuropathy in women. How often can we rule out the diagnosis? Oh, yeah. Well, alcohol is a definite cause of peripheral neuropathy, as well as cerebellar atrophy and a number of other things. Alcoholic neuropathy is pretty much invariably very painful neuropathy. It's a small fiber neuropathy. It's very painful. You may not see a whole lot of changes on nerve conduction, but you have the distal loss of temperature and pinprick sensation.
And it's not going to get any better if they continue to use any alcohol at all. So has to be complete cessation of alcohol. And then you just have to make sure they have plenty of thiamine and B12, et cetera, and wait for it to improve along with pain control, which is, as I said, things like gabapentin and duloxetine. But if a patient is abusing alcohol and has alcoholic polyneuropathy, again, that's often going to be associated with ataxia due to cerebellar atrophy, but 100% cessation from alcohol is required. Not just one glass of wine with dinner, but 0. Any other? Okay, I'll go on here. This is pretty rare, so I'm going to skip this one. Vasculitis, the rheumatologists tend to see this. Mononeuritis multiplex, the pattern I described before, multiple individual nerves, tends to be subacute, comes on over weeks to a couple of months. Abnormal rheumatologic serologies, other organs often involved with the vasculitis. And I'm going to redo this just to the only indication for nerve biopsy at this point. You can do a peripheral sensory nerve biopsy and you see the vasculitic infiltrates in the nerve. And this usually resolves or improves with immune therapy. So this is a treatable cause. So again, individual nerves, not symmetrical. And if a patient has pain without weakness, without any sensory loss, it's usually not neuropathic. You need to look for an orthopedic cause, and you have to do the physical exam. Hand pain, the first carpometacarpal, the joint at the base of the thumb, very common in gamers. If you see a young guy who's a little bit Aspergian and he says he has pain in his thumb, it's probably not carpal tunnel, it's probably this joint here. Plantar fasciitis, very common. I see it all the time. Patients referred for foot neuropathy because they have burning in their soles and it's plantar fasciitis. Pain in the thigh, iliotibial band syndrome is pretty common. So the basic principles, use the examination for the diagnosis, not just the history. If it's slowly progressive over years, distal, sensory predominant, not usually treatable. You're not going to get very far with a big workup other than, your standard blood tests. Other tests are low yield. I always do serum protein electrophoresis. Occasionally you can pick up some rare neuropathies that way. And if this has been going on for 5-10 years, nerve conduction studies are not going to give you any information that's going to give you a treatment. If it's rapidly progressive, though, and motor predominant, rapidly progressive weakness over weeks to months or even days, that's usually autoimmune. That's usually treatable. And so you need your immunofixation electrophoresis, lots of rheumatologic serologies, a CK level, nerve conductions, maybe with EMG, possibly a CSF analysis. So this pattern of rapidly progressive and motor predominant, you get very excited about. So questions, I've got a few very quick illustrative cases. Are there any questions before I go on? Nope. So 56-year-old woman with metabolic syndrome, pain in her feet for 6 months, worse at night. But she says she's had tingling and decreased sensation in her toes for at least 5 years, probably more, frequent nocturnal foot cramps. She has no back pain. Exam shows decreased pinprick sensation up to 3 inches above the ankles, slightly decreased vibration in the toes, normal position sensation, so both small fiber and a little bit of large fiber, occasional fasciculations in calves, no ankle reflexes. This is slowly progressive, length-dependent, sensory greater than motor. This is not going to be treatable. Case 2, a 23-year-old woman, no previous medical history. 3 weeks ago, she had decreased sensation in her left foot. That's gradually moved up into her left calf. She has no pain, she has no weakness, she has no back pain. In the exam, there's kind of mildly decreased pinprick below the left knee, but vibration and position are normal. The right leg and both hands are normal, strength is normal, but she has an increased reflex in the right ankle in the affected area. So this is unilateral, non-dermatomal, and with this increased reflex, I see Lynn Yaley's on the line. This is a common presentation in a young woman of multiple sclerosis. So the increased reflex and the non-dermatomal and the asymmetry are kind of clues here for you. Case 3, woman with previous, or man with previous medical history of dyslipidemia, 6 weeks, we're not talking years, 6 weeks of gradually progressive generalized weakness, clumsiness, falling, no pain, no numbness, mild tingling in the hands. Exam, he has weakness in the right shoulder all the way to the hand, and the left hand, left hip, bilateral foot drop. Pinprick is normal, vibration is decreased in the left foot, and there's no reflexes. No reflexes tells you demyelinating polyneuropathy. This is pretty rapidly progressive. And motor much more than sensory. So motor more than sensory, rapidly progressive. This is an autoimmune condition. This is a patient with CIDP. 72-year-old man, hypertension, dyslipidemia, obesity, COPD, complains of painful feet for the last 4 weeks. Pain is in his soles, it's burning and stabbing, but only with weight bearing. He has no back pain, he has no cramps. And his examination shows normal light touch, normal pinprick, normal vibration, normal position sensation, all the way to the tips of the toes. He has no weakness, he has no fasciculations, he has normal reflexes. Romberg is negative. He has an antalgic gait, which means it looks like his feet hurt when he walks. This is a patient with plantar fasciitis. The pattern is orthopedic. My feet hurt when I walk. Case 5, 65-year-old man, ex-smoker, no other previous medical history, 6 years, again, years, of slowly progressive hyposthesia in both feet, tingling, occasional pain, frequent nocturnal foot and calf cramps for the last 2 years, clearly peripheral nerve disease, cramps, distal, no balance impairment, decreased pinprick and vibration, large and small fiber, slight toe extensor weakness, so both motor and sensory, occasional fasciculations in the right calf, bilateral plantar muscles, reflexes within normal range except absent in the ankles, slowly progressive, distal, sensory greater than motor. This is just another patient where you're not likely to find a cause because it's been going on for years and it's mostly sensory. Last case, I think, 61-year-old man, 3 months, not years, of weakness and clumsiness of the right hand, 2 weeks of clumsiness of the left hand, falling due to tripping over his right foot, no pain, no numbness. He has severe atrophy of the right hand and forearm muscles, so peripheral nerve, severe atrophy, severe weakness at the right hand and wrist, normal sensation, mildly weak in other limbs, profuse fasciculations in both arms and the right leg and in his chest. Reflexes are normal except slightly increased in the right arm. So lower motor neuron and upper motor neuron disease, slightly slurred speech. This is a generalized motor neuron disease. Unfortunately, this patient has ALS. So it's been a kind of a whirlwind here. Are there any questions for those of us who've hung in?
I don't see any more questions in the group chat, but if you have questions, feel free to ask.
Okay. Well, thank you for attending.
Oh, someone
Anything
said
else?
yes. I don't know what, Stacy, do you have a question that you're asking? It looks like she's typing something out.
Yeah, it may take a few minutes for everyone to type out their questions. Feel free also, y'all can unmute yourselves, or you can ask to be unmuted and we'll unmute you there too. All right, Stacy, let's find you. Oh, hold on, let me see something. Okay, Stacy, you're unmuted now.
I enjoyed the presentation. Thank you so much. My question is the following. So it sounds like when we're making our referrals, not to beat a dead horse, it's really imperative to put the ethnicity, the duration of symptoms, weeks, months, years, whether or not, I guess the status of the deep tendon reflexes, whether or not it involves pain, and whether or not it involves any form of paresthesia. If so, where, in unilateral or bilateral?
Yeah, yeah, all of that. And then if you can put that all together into a like specific question, like, does this patient have polyneuropathy? Does this patient have carpal tunnel syndrome? Does this patient have a brachial plexus? That's very helpful as well if there's a specific thing, because again, it's not possible to do a complete neurologic examination in less than 2 days. It's just too complicated. So even the neurologists have to focus their neurologic examination on one particular part of the nervous system. So the more information we have, the more information you're going to get.
And then I can do labs. I guess it all kind of depends what I'm thinking at the time. I sometimes like to wait because you might want to add more things and trying to avoid multiple venipunctures. But I guess if I'm thinking of something, I guess it all kind of depends on the case.
Yeah, it depends on the case because based on the presentation and what you see on examination, you may order different labs. Like I say, if it's rapidly progressive, there's going to be a ton of rheumatologic things and immunologic things that you're going to want to order. But if it's been going on for 10 years, you're just going to order the basics, you know, your B12, your metabolic profile, make sure there's no liver, kidney disease, occasionally thyroid disease, but these are the labs you're already ordering. I would just add a serum protein electrophoresis into those if you're suspecting peripheral neuropathy.
And then could you walk back and talk about how the hyperlipidemia can exacerbate nerve pain?
Wait, could you repeat that? I had trouble hearing that.
Oh, could you talk again about how hyperlipidemia can exacerbate nerve pain?
How it works, we don't even know how hyperglycemia works in causing peripheral neuropathy. It's just that there is an association in people with metabolic syndrome, with hyperlipidemia, and worsened peripheral neuropathy. There's just an association. How it works, I have no idea.
Okay, thank you so much.
Sure.
Any other questions?
There is a question in the chat box, Dr. Doe, if you want to ask it. It's very critical.
The question is, what's the length limitation of a nerve conduction velocity test? Can it be used for a small area, for example, from the distal hallux to the first MTP joint? A patient was walking briskly, hit his foot on a table corner in August. He's had a swollen hallux with hallux extensor weakness and allodynia.
Yeah, well, first off, nerve conductions for podiatry problems tend to be somewhat unrewarding. you can't do small segments like that. There's just no way of doing it, and it's very difficult to record digital nerve signals in the toes. I mean, we do it in the hands, but for a small segment like that, nerve conduction EMG just not going to be helpful. I mean, for foot problems, you can diagnose generalized polyneuropathy with a nerve conduction study. Sometimes you can diagnose tarsal tunnel syndrome, but because people tend to have a lot of calluses on their feet, sometimes you just get no signals, which of course gives you no information. So I would say maybe 1 out of 10 times nerve conduction can diagnose tarsal tunnel syndrome, but for small things in small areas of the feet, you just can't measure that, so it's not going to be helpful.
There's a little bit of additional clinical info. So there was a normal MRI in this 22-year-old child person.
Normal MRI of what?
For that last case.
Normal MRI of the brain, the spine, the leg, what?
I'm assuming of the foot.
Of the foot, yeah. I mean, yeah, that's the thing. It's with small digital nerves in the foot, you can get limited information with nerve conduction and EMG, unfortunately. You can't, you really can't measure those tiny nerves that are going into the toes there.
Thank you. Any other questions? Oh, and some feedback. Lots of great feedback. A lot of thank yous for the great presentation. Oh, here's another question. Is rapidly progressive motor deficit more of a red flag than sensory deficit?
Absolutely. Absolutely. Yeah. Rapidly progressive motor deficit. That's something where you want to get on and call the neurologist and explain the case and get them in as soon as possible. Yeah. Rapidly progressive motor deficit, you know, over days to weeks is, that's a very urgent problem because often that's treatable, but the sooner you treat peripheral nerve diseases, the better the recovery is going to be. So yes, rapidly progressive motor deficit, very urgent.
Great. Any other questions? I think that may have been the last one. In that case, Dr. Collins, thank you so much for volunteering an hour of your time, hour plus of your time to get us all up to speed on peripheral neuropathy. Really, really appreciate it.
I hope the dog pestering me didn't bother people too much, but the dog came in a few times. All right. Well, thanks a lot.